Welcome to this Children's Safety Network webinar on resources and strategies from the Child Safety Collaborative Innovation and Improvement Network. I'm Jennifer Allison, Director of the Children's Safety Network, and I'm very pleased to be both a moderator and a presenter on today's webinar. Over the next hour, we'll be telling you about the work that has taken place in the Child Safety CoIIN to strengthen and improve child safety systems and programs and to reduce and prevent injuries. And this work has been underway for 2.5 years through 2 cohorts that have involved 21 states and jurisdictions in total. We'll provide an overview of the methods used in the CoIIN, and we'll pay particular attention to resources that have been developed through the CoIIN, such as change packages that provide information about evidence-informed and evidence-based strategies and programs for child safety, and outcomes data worksheets that provide guidance and tips for accessing real-time data on injuries and violence. And finally, we'll hear from Massachusetts, one of the states that participate in both cohorts of the Child Safety CoIIN, on the steps that it's taking to use lessons learned in the CoIIN in order to build a system of improvement for child safety. Before we get into the content of today's webinar, I want to let everyone know that the Children's Safety Network is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under the Child and Adolescent Injury and Violence Prevention Resource Center's Cooperative Agreement. And the information or content and conclusions in this webinar are those of the authors and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. I'm going to review a few quick tips to ensure that you don't encounter any technical difficulties during the webinar. So audio will stream through your computer speakers, and if you're having difficulty getting audio, please call our conference line at 1-866-835-7973 and mute your computer speakers. If you are calling in for the audio, we want you to know that phone lines will be muted throughout the webinar. And then you'll see up above the slides on your left a web links pod, and on the right a file share pod. In the web links pod, you'll find links to the resources that we're going to be talking about on the webinar. And in the file share pod, you can download a copy of the slides for the webinar, and you'll also see some resources from Nebraska, one of the states that participated in the Child Safety CoIIN. I also want to let you know that you can submit a question in the Q&A box at the bottom left of your screen at any time, and we're going to address questions during the Q&A portion of the webinar after the presentations. We're recording this webinar, and we'll send a link to the archived recording to all those who registered for the webinar. Here's a look at the webinar agenda. As I mentioned a moment ago, we'll start with an overview of the Child Safety CoIIN, delve into the methods, the change packages, and the outcome data worksheets used in the CoIIN, share some of the innovative strategies that emerged from the CoIIN, and hear a state perspective and state experience on applying lessons learned in the CoIIN to their injury and violence prevention efforts. You're going to be hearing from 4 presenters today, and I want to take a few seconds to briefly introduce each of them in the order in which they're going to be presenting. So Jenny Stern-Carasone is the Technology Director and a co-manager of the Child Safety CoIIN. She's worked in the youth development field for over 15 years, and her experience includes mentoring, juvenile justice, substance abuse prevention, violence prevention, and school enhancement. Jennifer Leonardo is a Quality Improvement Advisor and co-manager of the Child Safety CoIIN, and she has more than a decade of experience in public health and social work, program development and evaluation, capacity building, and facilitation. Bina Ali is an Associate Research Scientist at the Pacific Institute for Research and Evaluation, and she manages the Children's Safety Network Economics and Data Analysis Resource Center. Becca Thomas worked for the Children's Safety Network from 2013 through 2017, serving as a co-manager of the Child Safety CoIIN and as CSN's Associate Director. And in October of 2017, Becca became the Director of Injury Prevention and Control at the Massachusetts Department of Public Health. So I am now going to turn the floor over to Jenny Stern-Carasone to get us started with an overview of the CoIIN. Jenny?
Thank you, Jennifer. Hello. I'm going to open up our presentation today with a brief overview of the CS CoIIN, its development, and some of the key resources and tools that we've created to support the ongoing work. As Jennifer explained, the CS CoIIN was launched in December of 2015 with a two-day in-person summit attended by 65 leadership team members from all of the accepted states and jurisdictions. Cohort 1 was comprised of 19 states and 2 jurisdictions, and 67% of them remained actively engaged throughout the entire cohort. We opened up applications for a second cohort in January of 2017. 13 of the Cohort 1 states and 1 jurisdiction reapplied and continued into the second cohort, and we added 3 new states. The second cohort was launched with a 2-day in-person learning session in May 2017 and is summing up just now in May 2018. Thus, over the 2 cohorts, we've had a total of 21 states and jurisdictions actively participating in the CS CoIIN, and you can see them represented here on this map. Purple indicates states that were only in Cohort 1 and did not continue forward. The Child Safety CoIIN focuses on 5 leading causes of child and adolescent injury: child passenger safety, falls prevention with a focus on recreational and home-based injuries, interpersonal violence prevention, suicide and self-harm prevention, and teen driver safety. Our National Child Safety Initiative Steering Committee selected these topics after reviewing injury data and asking to what extent these topic areas drive the burden of child and adolescent injury. Then the Steering Committee looked at evidence base for child safety to see if there were interventions that could reduce these injuries, and also considered whether or not there was sufficient political will to address these topics. After that process, we then presented these topics to the leadership teams at the initial summit in December 2016 to capture their expertise for targeted improvement needs and strategies, and incorporated all of these into our change packages. The Children's Safety Network also compiled all of the data and information we collected throughout this process and produced a resource on evidence-based strategies and related research across the 5 topic areas. This resource is available here in the webinar in the web links pod at the top of the page and also on our CSN website. Here's a chart that is showing the basic structure of the CoIIN. The CoIIN is structured to assure support from state leadership, engagement of injury prevention staff, as well as the testing and implementation of strategies to effect change. There are 3 types of teams outlined on this slide, and I'm going to talk a little bit about each of them. First, the leadership teams. These are comprised of state or jurisdiction health officer, the maternal and child health director, and the injury prevention director. This team provides guidance and accountability for the state's work in the CoIIN and gives support and direction to the staff who are actively involved in the CoIIN, helping them to overcome any barriers and solve problems that they might incur. Second, we have strategy teams. Strategy teams consist of key staff and external partners who are working on one of the Child Safety CoIIN 5 injury topic areas I just described. Each state forms one strategy team for each of the topic areas that they may choose. The specific composition of a strategy team depends to a great extent on which change ideas the state selects, but it's really important that every strategy team has a coordinator, a data manager, and representation from key partner organizations. Additionally, the work also involves recruitment of sub-teams consisting of the frontline workers of pilot sites. So each strategy team can look very different from state to state. Finally, we have the topic teams. The topic teams include all of the strategy teams from the various states that are working on a particular injury topic area. Topic teams share their experiences on monthly topic calls, and these calls are a place where most of the cross-state sharing and learning occurs. Participating states and jurisdictions were able to select which topics that they wanted to work on, and then they developed their strategy teams, recruiting membership from diverse sectors that would enable them to address the change ideas that they were interested in. Here we see the states and jurisdictions that are participating in Cohort 2. This represents a total of 16 states and 1 jurisdiction. We have a total of 34 strategy teams since some states selected more than one topic area. Over the course of the entire CS CoIIN, we've had 45 strategy teams. But as we moved into Cohort 2, drawing upon the lessons that were learned in Cohort 1, many of the ongoing strategy teams decided to select a smaller number of topic areas, recognizing that working simultaneously on multiple topic areas can be very challenging, and a more focused effort is likely to be more productive. Teams were then able to revise their improvement strategy that they had from Cohort 1 moving into Cohort 2, and many refined the number of change ideas they were addressing or the process measures that they were collecting. As you can see here, we have one state, Florida, that selected all 5 topic areas to work on. 4 states, Kentucky, Missouri, Tennessee, and Texas, selected 3 of the topic areas. 5 states and 1 jurisdiction selected to work in 2 topic areas, and the remaining 6 states selected to only work on 1 topic area throughout Cohort 2. Now that you understand the structure of the CS CoIIN, I just want to describe a little more about how it works. The CoIIN is developed around 3 primary premises: to establish senior leadership and adopt systems thinking to identify gaps and needs, to start working on improvement, to commit to continuous learning and innovation while doing the work, and using data to inform decision making. You're going to hear a lot more about this in depth throughout the rest of the webinar. But before I move to that, I want to just address another essential part of the CoIIN, which is the collection and use of data. There are many achievements across the CoIIN that we'd like to celebrate, but this slide illustrates just a few. Some examples of innovative data collection include the following. Within the topic of suicide and self-harm prevention, the state of Massachusetts is testing the use of data from the Massachusetts Ambulance Trip Record Information System as a proxy for ED visits and to identify young adults that are experiencing a psychotic episode and provide follow-up services. In the topic of falls prevention, the state of Tennessee has been testing the use of the Traumatic Brain Registry for TBI-related hospitalizations and deaths in order to be able to access real-time data. This has enabled them to assess what they're doing and make decisions about areas for improvement throughout the CoIIN. Here are some other statistics that illustrate the far reach and influence of the work being done throughout the topic areas of the CoIIN. Teams have experienced improvement and increased engagement in many of their strategy areas, including engaging schools and teaching teens and parents about graduated driver license laws, increasing the submission and analysis of children car seat inspection forms, and helping teams understand how to de-escalate situations and prevent bullying and other forms of interpersonal violence. To summarize, here's another visualization of how the CoIIN works. As participating teams seek to improve their injury and violence prevention system, they start by developing their aim through scanning their environment and accessible plans and resources in order to determine areas that are ripe for improvement. Next, they build an action plan to test and implement key programs and strategies. CoIIN teams accomplish this by choosing an injury area that they wanted to focus on and then utilizing the CoIIN change packages to determine the drivers and change ideas that they would address. Finally, to launch their action plan, teams created PDSA cycles to develop, test, and implement their strategies, and then collected, reported, and analyzed monthly data to determine what was working and what needed further improvement. Before I pass the baton on to Jennifer Leonardo and Bina Ali to learn more about the specifics of this process, I'd like to pause for a short poll just to get a sense of the audience's familiarity and use of quality improvement. So if you just take a moment here and click on which statement best describes you and your involvement or knowledge of quality improvement. And if you have something other than what's listed there on the list, please just specify in the chat below. So it looks like many of the audience today is very familiar with the model for improvement, which is what we utilized in the Children's Safety CoIIN, but there are many other models that are utilized for quality improvement work that you may be utilizing in your own work. We're going to dive a little bit more into the model for improvement as I now hand the baton to Jen and Bina to talk more about methodology and methods for improvement. And I think that Bina might be on mute. Or Jen is muted. Well, as we wait
Can
for
you
one
hear
of
me,
them,
Jenny?
yes, we can. Okay, it may be that Bina is having some difficulty with her audio connection. So Jen, I'm going to go ahead and let you get this started.
Jenny, can you hear me?
I can indeed.
Yep, we can hear you.
Okay, this is my section, so I will take these slides. Okay, sorry about that, folks. About 60% of you are familiar with this model for improvement. So for the remaining 40%, I hope I provide enough information here, but for the 60%, I'll tell you some of the adaptations that we have made. The model for improvement consists of 3 primary questions and a plan, do, study, act framework for testing change ideas that are evidence-based. So the first question asks, what are we trying to accomplish? What does the collective group of states and jurisdictions in the Child Safety CoIIN want to aim to accomplish? And what we have are 3 main outcome measures: the reduction of hospitalizations, emergency department visits, and fatalities. The second question in the model is asking, how will we know that a change is an improvement? So this is pushing our teams to think about what measures do you need to have in place so that you can start to collect data and you can ask yourselves along the way, is what we are seeing an indication that we are having some improvement? If it is, that's great. Let's continue, and what more can we do? If it is not, then should we stop doing this? Should we tweak it? What else should we be doing? And then the third question asks you, what change can we make that will result in improvement? And the important part here is that these changes are child safety promotion strategies or evidence-based programs, and they all need to be evidence-based or evidence-informed. And I'm going to take you through a couple of examples of these across a few of our topic areas. I will say a little bit about the Plan, Do, Study, Act cycle. It really is intended to encourage states and jurisdictions to start to test on a smaller scale, to be able to adapt any of the child safety strategies or programs, and to be able to use their resources, which we know are always limited, in a really effective way before they start to implement and spread widely across their state. What we have done is we have pulled together what are called change packages. And these change packages are really the guide for the Child Safety CoIIN states and jurisdictions in their work. The change packages consist of a common aim statement, a driver diagram, which is a theory of change. It is a compilation of all the evidence-based strategies and all the evidence-based programs that we believe are needed to accomplish that common aim. And then there's a measurement strategy with a lot of guidance around the type of data you would collect, how you would collect that, and with what frequency. And the change package is intended to really spur innovation at the local level. So really taking within the literature, testing it out at the local level, and making adaptations, and then sharing that learning back with other states. Here we have the example of the aim statement. The overall aim statement is to decrease the rate of injury-related deaths, hospitalizations, and emergency department visits among 0 to 19-year-olds. We then went and we crafted aim statements for each of the 5 child safety topic areas. And that was based on looking at state trend data for the participating states and jurisdictions in the CoIIN and looking at the literature for the strategies and the programs that we have in our driver diagrams. We were flexible in offering each of these 5 aim statements respective to the topic teams to the states and saying you can either adopt this common aim statement, but if based on your state data or new knowledge that you have, you would like to make an edit to that aim statement, you can do that as well. And so we did find that that was really important with the Child Safety CoIIN, was to retain a level of flexibility so that all states and jurisdictions could really make the model for improvement work for them. The Child Safety CoIIN measurement strategy includes both outcome measures, which are long-term measures. Those are the 3 that you saw in the aim statement: the hospitalizations, the emergency department visits, and the fatalities. And then a menu of process measures for each of those 5 child safety topic areas. And these are intermediate level measures. We pay a lot of attention to these in the CoIIN. And we asked the states and jurisdictions to select 5 to 7 measures from the measurement strategy, to report that data monthly, to talk on monthly topic calls about the data they're collecting, what they're learning, some of the challenges that they're experiencing, some of the successes that they are experiencing. And we also, again, offer this level of flexibility to states and jurisdictions that they can test out new measures. And they share that with us. And what we do is we sometimes go and revise the change packages based on what they're learning along these new measures to include those for other states. So I want to talk a little bit about this other question in the model that asks you, what changes are you going to make? That third question. And that gets at the driver diagram. What we know is that multiple interventions are needed across multiple levels of a system in order to impact population health. So this model is likely familiar to a lot of you. It is a social ecological model. It's used by the Centers for Disease Control and Prevention. And you have here different levels of the system that we intentionally ask ourselves, what are those change ideas at each of those levels that are evidence-based or evidence-informed that are high leverage points that we want states to be thinking about and thinking about spreading widely. To recap a little bit, something you may see at the societal level would be to work on change ideas around establishing shared norms that could perhaps include running campaigns, promoting social messages. At the community and the organizational level, you're really looking at the practices and the policies of different agencies, be they schools, health clinics, community agencies. At the relationship level, you're starting to look at a lot of education with, in this case with teens and children, looking at their mentors, their parents, their athletic trainers, coaches, doctors, etc. So who are those people that are close to them? And then at the individual level, really how are you disseminating and working with teens, disseminating the education and working with those teens to really shape their attitudes, their beliefs, and their behaviors around safety. I'd like now to show you samples of our change packages. So if you remember, the change package has the aim statement, then it has the driver diagram, and it has the measurement strategy. So here I have a portion of the teen driver safety driver diagram. And you'll see over on the left-hand side, I have a primary driver. And there is consistency across the 5 topic area change packages. They all have this same structure, the primary driver, the secondary driver, and the change idea. The primary driver is going to be what we believe is necessary to achieve that overall aim of the reduction in the 3 outcome measures. And we organize the driver diagram according to primary drivers that sit along the social ecological model. So here we have one at the relationship level, that families and teens are knowledgeable in teen driver safety best practices. The secondary driver is to have interactive learning and dissemination of educational materials. There can be more than one secondary driver for a primary driver. And here are a few of the change ideas that we have from the teen driver driver diagram. So providing a primer to parents on teen driver safety and educating parents and teens about driving agreements. An example of a measure that would go along with these change ideas would be the percent of parents reporting enforcement of GDL with their teen driver. And you can see that we provide information for the states and jurisdictions on how they would operationalize this measure. And what we find is that providing technical assistance around establishing the denominator, the target population, has been very helpful. So who are the parents that we're looking to report enforcement of GDL with? Where are they in the state? How are we going to access them? Are we going to be accessing parents through schools who are offering GDL education, for example? So let's get a sense of what that population of interest is. And then the numerator becomes the number of parents that report enforcement. We ask the states to report this on a monthly basis, or we ask them to take samples of parents, if they're working across some different sites like schools, and to report that monthly as well. If you recall, after the 3 questions in the model, you had the Plan, Do, Study, Act framework. Here's an example from one state from teen driver safety. They were working on improving the awareness of and adherence to graduated driver licensing. So they had a plan. They said, let's do a small test of change. Let's test out a new informational card that we are developing on graduated driver's licensing. And they asked 5 parents to fill that out. And 5 parents can yield enough information. Even a sample of 1 can yield good information. So they had a prediction that 4 of the 5 parents would find the card informative. They went and they showed the card to the parents. They received feedback that 5 out of 5 parents found that card informative and that they reported gaining knowledge about GDL through the surveys that they filled out. And then the state went and they adapted that card based on the feedback that they had received from the parents, and they decided to take further action in doing the same process with law enforcement and with driver's education teachers. So this is an example of how this change package was used and how it led to the PDSA cycle. Here's another example from child passenger safety. This is one from the organizational level. And if we look over at the right-hand column, the change ideas, we have maintaining an optimal number of child passenger safety technicians. The second one is to establish mobile fitting stations and car seat inspection stations. And the third is to establish sites that distribute free or discounted child safety seats and booster seats. So a measure that went with that change package, with that change idea about the sites that operate mobile fitting stations is just to track that number. How do we get more mobile fitting stations and car seat inspection stations in our communities? So this is an example of a measure that's a number, not a percent. So we don't have guidance in the numerator and denominator column, but we do ask, because it's a number and we don't have the denominator, that target population, we ask, what is the goal? So over the course of a year, how many sites are you hoping to have established? And we do ask for this data, again, to be reported monthly. We also will ask for some of these measures for the states to think about while you are collecting that data already, while you're partnering with these sites, is there any other additional data that's available or useful to track? So for example, here there's some guidance that you may want to track the number of car seat inspections that are performed, because this just gets one step further down the line of impact. So we really try to coach the states through thinking about what measure is feasible and what is the best measure, what is the closest measure to those outcome measures that we can work on. And here's an example of a PDSA from the child passenger safety work. And this is a state who said, we know that we have some good, successful strategies running in our state already, but we know that not all of our counties have sites established. And so they went ahead and they decided that they were going to roll out this PDSA cycle and invite a working group to come together. They made a prediction. They knew not everybody would be coming, and they wound up getting about 50%. And then they identified where those counties were, 19 counties, that needed to have these strategies in place, and they were able to come to consensus on which strategies to implement. I'm going to ask for 1 minute or for Jenny to jump in on a couple of slides because my computer just crashed and it is reloading. So Jenny, can you take us briefly through the interpersonal violence prevention example?
Absolutely. So
Thank you.
as with the other examples, here we see an example of some of the drivers and change ideas that are associated with the interpersonal violence change package. And you can see here that this is at the relationship individual level about increasing family and youth knowledge about interpersonal violence prevention through training and education, and that the change ideas that are associated with that are building parent skills through evidence-based programs, teaching adolescents nonviolent skills through things such as safe dates or coaching boys into men, or developing youth social and emotional skills through participation in evidence-based programs and curricula, such as the Incredible Years or other examples of that. Similarly, a measurement strategy that might be associated with that would be the percent of children and youth receiving evidence-based social emotional learning, positive youth development, and nonviolent skills. As with the other examples, we again provided guidance on how to define the numerator and denominator and some suggestions on how to collect that data. And again, as with all of our other measurements, we asked for that reporting to occur on a monthly basis. And here is an example of a PDSA in interpersonal violence with the use of the program Green Dot. So here in the plan, the prediction was made that 50% would be proactive and 50% would be reactive green dots in the Green Dot program. And they would measure that by collecting and looking at the percent of proactive and reactive dots. Then as they proceeded forward, they realized from looking at that data that the program, while it was evidence-based, was not serving their population, and they thus created an additional field in the sexual violence data registry to separate proactive and reactive green dots and collect that data monthly so that they could better ascertain how the program was working on addressing sexual violence. They established baselines and looked at the data and then decided to adopt the idea by integrating an increased focus on dating and sexual violence in their Green Dot sessions to better address helping to reduce sexual violence injury issues and implementing the Green Dot program since the data showed that it was successful. Jen, are you back on? Did you want to summarize before handing it off to Bina?
I am still logging in, Jenny. Thank you. I think that you can hand that off to Bina to talk about the outcome measures.
Okay, so before I hand it off to Bina, just in summary, the use of the CoIIN change packages, again, are that the change packages came with a lot of information. We encourage teams to make revisions to the aim statement that we provided based on their own state or local data. We then had them go through and work as a team to select their drivers and change ideas to allow them to accomplish that aim. They then selected measures that would allow them to monitor progress towards their aim and gave them some flexibility in being able to leverage data and look at measures that they might already be collecting and reporting on for other programs. And then we gave them technical assistance and support so that as they tested, adapted, and implemented and spread their change ideas, that they were able to go back and continuously review their data and ask what progress that they were making towards their aim and whether there needed to be any additional changes in order to secure improvement. So the key is to be flexible and open to learning as you test your theory of change and make improvements. And I will now hand this over to Bina to talk more about the outcome data aspects of the CoIIN work.
Thank you, Jen and Jenny. This is Bina. Hi, everyone. I will talk some more on outcome data. The CSN is structured to allow testing and implementation of CoIIN strategies. Monitoring data and incorporating that data into a decision-making process allow us to effectively adopt and scale up strategies. So in other words, real-time data can inform and accelerate improvement. We often rely on national-level data to inform our injury work. However, national-level data typically has a lag time of 2 to 3 years before they become available to public. For example, we're currently in 2018, and the latest national fatal injury data that we have access to is from 2016. The delayed time when data become available creates a challenge for those who are working on the ground and who are testing change ideas rapidly on a small scale in order to remain innovative and make informed decisions. So in this table, you see types of data sources for mortality, morbidity, and behavioral risk factors. To explore ways to obtain data more rapidly, CS CoIIN teams were encouraged to work with their local health departments, hospitals, and other agencies and institutions that maintain relevant data. CSN developed tools to assist teams working with epidemiologists and other data experts to define type of outcome data they were looking for. In the next few slides, I will highlight some outcome data tools that CSN created. So CSN asked the CoIIN teams to collect and report real-time data for the purposes of quality improvement and to determine the impact that the work is having on the rates of topic-related hospitalizations, emergency department visits, and deaths. CSN emphasized to the CoIIN teams that clean data are ideal, but often unavailable in real time. So CoIIN teams were asked to explore their options and report what they could in real time. The rationale for that was some data is better than nothing. So on this slide, you see an example of outcome measure worksheet that was developed for child passenger safety. In the outcome data worksheet that CSN developed, teams brainstormed what kind of information might be available from their state. So they identified their data sets, which data sets were used in their state, who are the individuals responsible for reporting to that system. Teams could then contact those individuals and explore options for getting real-time data on a monthly basis. So collecting real-time data has been one of the most challenging yet most innovative aspects of the CoIIN. Injuries had to be defined and standardized. CSN defined injuries through ICD-9-CM and ICD-10-CM codes for non-fatal injuries and ICD-10 codes for fatal injuries. Emergency departments and hospitals transitioned from reporting non-fatal injuries in ICD-9-CM codes to ICD-10-CM codes starting October 1st, 2015. To help with this transition, CSN developed a crosswalk for ICD-9-CM to ICD-10-CM codes. CSN also helps brainstorm potential data sources, as I discussed in my previous slide, and CSN staff conducted topic calls, trainings, and one-on-one technical assistant calls to further support teams and clarify the quality improvement, use, and interpretation of these data. Teams were regularly reminded that within a quality improvement context, data needs to be sufficient for informing decision-making, not totally clean as it is required in some other data settings. So this allows teams to work rapidly and in real time. So over the course of CS CoIIN, 8 states, including Connecticut, Florida, Indiana, Kentucky, Massachusetts, Tennessee, Virginia, and Vermont, began reporting real-time outcome level data, partnering with epidemiologists, identifying new data sources, and using data to inform decision-making. CSN encouraged teams to be innovative in their real-time data collection, and in CoIIN, teams varied in their data collection and reporting due to various reasons. CoIIN teams who already had epidemiologists or working with epidemiologists in their states were able to collect data more effectively. Some teams used creative approaches to identify and work with epidemiologists and other agencies to house data. CSN observed several success stories of innovative real-time data collection, and as a result, CSN published stories of innovation capturing real-time outcome data collection strategies. This resource is available on the CSN website. The CSN also compiled a list of commonly used injury data sources. In this table, the first column lists data source, example CDC whiskers that provides population estimates on fatal and non-fatal injuries. National Violent Death Reporting System, or NVDRS, that could be used to examine violent deaths, and Fatality Analysis Reporting System, or FARS, for traffic-related fatalities. The second column indicates years when the data have been collected. The third column shows whether data provides state-level information, and the fourth column has links to access the data. This table is not a comprehensive list, but a list of commonly used injury data sources that are easily accessible and can be used in injury prevention work. This table comes from the CSN's Injury and Violence Prevention System Toolkit paper that is currently under development, and it will be shared as a resource. So I will now pass to Jennifer Allison, who will share some more innovative strategies within CS CoIIN.
Great, Bina. Thank you so much. So I am going to talk about some innovative strategies that have emerged from the Child Safety CoIIN, and the attention on child safety and on program improvement that's occurred in the CoIIN has produced some genuinely new approaches to child safety. Before we get into that, I just want to ask a quick poll question, so we're pulling that up on the screen now. The question is, which of the following injury topic areas are you currently working on? Choices are child passenger safety, falls prevention, interpersonal violence prevention, suicide and self-harm prevention, and teen driver safety. These, of course, are the topic areas of the CoIIN. So it looks like we've got some results coming in here. People are still responding a bit, so I'll give it a second. Okay, 66, 64 25% are saying child passenger safety, so clearly a majority of folks are working on that. Around 31, 32%, or maybe even 33% are saying falls prevention. 36% roughly interpersonal violence prevention, around 18% suicide and self-harm prevention, and 40% teen driver safety. All right, great. Very helpful, good to know. So I just want to say a few words about cross-cutting change ideas. Jen and Jenny had talked about the change packages developed through the CoIIN. Jen explained that the change packages are organized based on the social ecological model. So what that means is that we can look across all of them and see some cross-cutting strategies for advancing child safety. And I just want to point out a few from this slide. So at the societal level, for example, we can see the importance of multi-stakeholder partnerships. The CoIIN itself is based on a structure that relies upon multidisciplinary teams. Jenny made that point in her presentation. So coordinated, cohesive groups of stakeholders and partners to get things done, and identifying key stakeholders, getting them to the table, mobilizing them to work together is crucial for making headway on child safety. And then at the community and organizational level, we see increasing access to programs, services, and safety equipment. And the focus on access has been a real point of emphasis and attention for the Child Safety CoIIN because it's crucial to find the most efficient and effective ways to get information, programs, safety equipment, and data, as we've just heard, into the hands of people who need it. And then at the relationship and individual levels, we see interactive learning and dissemination of educational materials. So the change packages emphasize interactive learning, like teach-back opportunities for parents to learn how to install child safety seats correctly, parent and teen agreements for teen driver safety, and training home visitors and others to address child safety. And then here are the major types of innovative strategies that the CoIIN states developed and implemented. So I'll just go down the list here, providing a bit more detail on some of these. So use of technology for child safety. One state pioneered the use of an app and an electronic version of a child safety seat inspection form to be used at inspection stations, greatly increasing the quantity and quality of data that the state was able to collect from the inspection stations. And I'm going to jump ahead here just so we can see in a little bit more detail what that state did. So tablets were provided to child safety seat inspection stations in the state, and staff at those stations were trained in the use of an app. The app makes it possible to submit inspection forms to a database with the push of a button. So the use of the app enables more accurate data reporting and targeting of specific populations or regions based on the data. And when the evaluation tool is introduced, as they hope it will be, the state anticipates being able to provide feedback to child passenger safety technicians on knowledge retention and satisfaction with the interaction to improve the quality of inspections and ensure consistent quality across inspection sites. Now I'm going to go back to my list and say a bit more about the other strategies listed here. So use of incentives for child safety. Another CoIIN state required organizations that receive car seats for distribution to become child passenger safety inspection stations. Great use of an incentive to persuade these sites to make a larger commitment to child safety. Another state provided incentives to parents to encourage them to sign up for trainings in teen driver safety. So the state worked with a school to provide student parking passes when education in teen driver safety was completed. So you'll want to consider what kinds of safety information and equipment you can distribute to sites and determine if those can be reframed as incentives to get greater commitment and a deeper level of participation from the sites that you work with. Then cross-sector training. So police officers and cadets were trained to be child passenger safety technicians, safety standards, combining an emphasis on standards and incentives. One CoIIN state established specific safety standards for intramural youth sports leagues and recognized and rewarded the leagues that met those standards. And you want to think about the standards that you want organizations to adopt and adhere to and see if there are tangible ways to recognize organizations that meet those standards. And organizations might be more willing to provide documentation on their compliance with standards if the request for documentation gets combined with an incentive, wider recognition, or a reward. And then integrating child safety into home visiting. So one state worked to incorporate safety assessments into an asthma home visiting program. Partnerships, another state partnered with its Department of Motor Vehicles to spread education on the state's graduated driver licensing requirements to parents and teens through an informational card. Jen showed PDSA that this state did. And the information was included in a Department of Motor Vehicles handbook. And I'm going to just jump ahead here for a little bit more detail on that. So you can see that the state went through a very thorough process of developing this card, testing it thoroughly with parents and teens, making revisions, and then finally partnering with their Department of Motor Vehicles to distribute the card. And back to our list here for the final strategy, learning collaborative, use of a learning collaborative to implement and spread a strategy or program. So a learning collaborative is a great way to get organizations directly engaged in implementing and spreading a program. You can provide ongoing training to participating organizations and engage them in group problem solving when challenges occur. And I'm just jumping ahead here to another slide showing a little bit of a breakout on how one state in the CoIIN used a learning collaborative. They were working on spreading zero suicide, which is an initiative for suicide prevention. So they're working with healthcare and behavioral health organizations in the state. They formed a steering committee to get things rolling. They held regular meetings, providing an opportunity to talk about the different program components. So learning collaborative is a particularly good approach if you are trying to implement a complex program, because it provides a little bit of an infrastructure for working through the challenges that will no doubt occur when you're trying to implement that kind of a program. And then they provided technical assistance to organizations to enable them to implement all the components of the program. So with that, I am going to now turn things over to Becca Thomas, who is going to tell us about the experience that Massachusetts had in the Child Safety CoIIN and the work that they've been doing to build a system of improvement. Becca?
Great. Thanks so much, Jennifer. And I know we're running short on time for today's webinar, so please feel free to enter any questions you have for me or any other presenters into the Q&A box on the left-hand side of the screen, and we'll get to them as we can. So my name is Becca Thomas. I'm the director of the Injury Prevention and Control Program at the Massachusetts Department of Public Health, but I did have the great fortune of working on the CS CoIIN for a few years and with Children's Safety Network for several years. So coming into the Department of Public Health, I was trying to apply this framework that we had established through the CS CoIIN and meet this little synergistic spot between program management and quality improvement. So for that, I really had the perspective of good management and good outcomes requires a continuous quality improvement lens. One thing that we taught in the CoIIN and that we continue to elaborate on is the importance of building the system of improvement. We use the improvement guide as a reference document for this CoIIN, and it's also used for most of the other CoIINs that you hear about in the state or any other or in the country, as well as other continuous quality improvement projects. The 5 components of the building of the system of improvement is to establish constancy of purpose, which is really that aim statement. Why are you all coming together to do this work? The second is understanding your organization as a system. Third, designing and managing a system for gathering information for improvement. Fourth, conducting planning for improvement and integrating it with strategic planning. And then managing and learning from a portfolio of improvement initiatives. Now, these are not things that happen in isolation from one another. You don't do step 1 and then all the other steps come later. This is an iterative process and they all interact with one another. So I knew walking into this really well-established historic program, it's one of the oldest, if not the oldest, injury prevention program in the United States, that we would need to work collaboratively to build this new system and apply this new methodology. So one way to start to think of that is to identify all the strategic initiatives that make up your program. This helps get to that point of thinking of your program as a system. In my little unit, we have child fatality review, emergency medical services for children, infant safe sleep, older adult falls, poison prevention, spinal cord injury research, transportation safety, and youth sports concussion. So there's a very large group of strategic initiatives that is actually only supported by 5 program coordinators, me, the manager, 1 embedded epidemiologist, but it also has the larger system surrounding it. So we have about 3 epidemiologists who do surveillance work and support the programs in one way or another, and then this massive system beyond that with a whole gamut of different programs and services. So we're just one little system embedded in this very massive state bureaucracy. I knew to be successful in this, based on what I've learned from the CoIIN, we needed to ask ourselves a few key questions. We had to prioritize our improvement projects. So what should take place first? If there's more than one thing, can they take place at the same time, or do I really need to separate them out? And for how long should I be focusing my energy on those improvement processes? And that was my very first lesson at the State Health Department. Someone told me, you're going to have a really hard time moving everything forward at once. You have to take a step back, take a deep breath, and choose what you want to move forward now and focus your energy there. So lucky for me, I was able to identify a smaller portfolio of improvement projects within my strategic initiatives, and those are focusing on our child fatality review program, as well as designing consistent program management and documentation. The reason that I selected those is, 1, child fatality review had already started an improvement process with an external agency, so I knew that the opportunity was ripe and now was the time to keep on working on that. I also prioritized the consistent program management and documentation because rather than managing these different strategic initiatives as individual programs and projects, I needed to bring them all together and have some consistency. I don't have the capacity to oversee 6 programs at the same time. I really needed everybody to work together. So that's why I need those consistent management tools. The consistent program management documentation piece includes providing professional development opportunities for the staff on the team, establishing management tools such as standard processes for developing and reviewing materials, consistent program documents like talking points, program guides, templates for membership tracking, because we have about a dozen advisory groups, coalitions, and statutory commissions just within our little unit. And that prioritization requires, and you'll hear this in any continuous quality improvement project or work group, it requires dedicated staff and leadership. So I needed to make sure that some tasks were taken away from the person who needed to focus on this more and increase that person's time on the project. So for our child fatality review coordinator, she is also our safe sleep coordinator. I told her that for the next 6 months, I really need her to dig in deeply on child fatality review while I help backstop and take on some more of that infant safe sleep work so that nothing comes to a complete standstill or halt, but we have one person who's dedicated to really getting those improvement pieces in place that we can push through as time goes on. Another lesson that I've learned is by telling everyone that I'm approaching this as a PDSA cycle, a Plan, Do, Study, Act cycle, they've been much more comfortable with the changes that are being made. By saying, this is a small test of change, we're going to try this once, maybe twice or 3 times. If it doesn't work, then we'll go back to the old way, or we'll go back to the drawing board and try something new. It's disarming. It really helps people see, okay, this person's not trying to completely upend the system and force something on me that I don't want to do, but let's give this a try. Maybe this will make my life a little bit easier. And then we also want to make sure that we're consistently reviewing the progress that we're making. And I do this in our staff meetings. It's still something that I'm working on, making sure that people understand the full picture of the improvement project, making sure that we're reviewing any successes that we have had and pushing together that mutually agreed upon portfolio of improvement projects, and agreeing on the barriers and emerging issues. So how did that PDSA go? How did that small test of change go? Did it work for you? Did it not work for you? Do we need to go back to the drawing board? And making sure that the improvement plan is continually growing. You never want to get stagnant in your work. And making it fun and easy. Optimism for me has got a long way as I've transitioned from the CSN over to the Department of Public Health. I want to make sure that we're incorporating all of these new concepts into what already exists. Nobody has time for additional meetings. We want to make sure that people feel positive and empowered, and then being flexible and going back to the beginning if we need to. So everything is always in pencil on our team. So in summary, the lessons that I've learned in these very short 6 months, people tell me I have 5 years to still be a newbie at the Department of Public Health, is that you can't do everything all at once. You have to make space for your priorities. Small tests of change are disarming, and consistent documentation and communication improves buy-in and collaboration across the team. So with that, I'm going to pass this back over to the great team at CSN to help field any questions that you all have.
Okay, thank you very much, Becca. Great information, very interesting. And I do want to just take another moment to remind folks that you can find the resources that we've been talking about on today's webinar on the Children's Safety Network website at www.childrensafetynetwork.org. So you'll find CoIIN resources, the change packages, the outcome data worksheets, as well as many other CSN resources on a variety of injury prevention topics on that website. So we certainly encourage you to go there and download those resources. We do have just a few minutes left for questions. If folks want to type questions into the Q&A box on the left. I've got a question actually for Becca. I thought, it was interesting you talked about making sure that the staff, people who were working on these efforts, had sufficient time to do this kind of work, and then reviewing the progress with the staff. I was wondering, are there other strategies that you've used to get staff buy-in to help in building the system for improvement?
I think the optimism and pointing out that if we do this differently, we're working smarter, not harder, has gone a long way. There's a cartoon that the CS CoIIN has used in the past, that's these little Lego men pushing a wheelbarrow that has a square wheel on it, and someone is standing behind them with a round wheel saying, I have something that would help you, and the people with the square wheel are saying, I'm too busy, I can't do that. So it's putting that in front of everyone and saying, this is broken, this is time consuming for you, this isn't working, and we're not seeing the outcomes that we want to. How do we get to that place where you feel comfortable and confident and empowered in your work, and make sure that it's achieving those outcomes? So I think that's really putting it in front of people that this will make your life easier if we try something different. And if it doesn't make your life easier, then we'll go back.
Great. All right. I think that's good advice and a perfect note on which to conclude today's webinar. We are just about at the top of the hour. So I want to thank everyone for joining us for the webinar. We hope you found this useful. And again, we really, really encourage you to go to the CSN website and check out those resources. Then, as I mentioned at the outset, the webinar was recorded and it's going to be archived. So we'll be sending a link to the archived recording to everyone who registered for the webinar. And then we do have, I believe, a short evaluation form, so we'd really appreciate getting your feedback on the webinar, and we ask that you take just a couple of minutes to fill out and submit that form. And that is it for today's session. Again, thank you for being part of this, and we'll see you at the next Children's Safety Network webinar.